Hello, my name is Jennifer Harris, and I will be talking about justice-involved individuals and communicable diseases for my health disparity population today. Justice-involved individuals are also referred to as individuals in custody, the incarcerated, and even prisoners. For purposes of this presentation, you will hear me refer to them as justice-involved. There are almost 2 million individuals in the justice system within the United States. Communicable diseases disproportionately impact this population for multiple reasons that we will explore. Additionally, we'll explore interventions that have failed as well as succeeded and potential solutions for the future. In 1976, there was a court ruling titled Estelle v. Gamble, and it deemed that it was unconstitutional to deny justice-involved individuals access to health care services. Despite this being 48 years ago at this point in time, health disparities still exist in this population with detrimental results. These are some statistics comparing the U.S. population to those in our justice system. You will see that for gender, as an example, it is extremely disproportionate. In the United States, our population is approximately 50-50, but within the justice system, you can see that 93% are male, with just under 7% representing females. You can also see when comparing race statistics that the U.S. population is very different than what you will experience or see within our justice system. As an example, Blacks and Hispanics are significantly disproportionate within the prison systems. Blacks, for example, are at approximately 37%, while they only represent about 14% in the U.S. population. While there are whites in the U.S. accounting for about 75%, but within the prison systems, you will see only about 34% of them. So again, the disproportionate, simply just based on these demographics, is very different within the prisons. Similarly, age is very different when you compare the U.S. population to the justice involved. You can see here that middle age is disproportionately represented within the justice system at 32%, while that age group, 35 to 49, only accounts for 19% of the total U.S. population. It starts to decline from there and become a little bit more in line. But one interesting thing about this is the U.S. Census Bureau does not collect specific data for those 65 and older into further categories, whereas the justice system does. And what you can see there is that you have approximately 10% that are in a category of 75 and older, and then even older than that, 3% within the justice system. The justice system has a growing problem that I will not address in this presentation, but with aging individuals and their development of age-related illnesses that they are not prepared to accommodate. Some of these illnesses include dementia, cancer, immobility disabilities, wheelchairs of the such. They are not ready to handle that, and that's a different topic for a different time. But I bring this up to point out how much the age statistics within the prison system contribute to some of the health disparities that we will talk about. Some of the reasons that I would like to explore for why this is such a health disparate group or population is because of their social determinants of health for the justice involved. The justice involved tend to have, on average, lower education levels as compared to the United States. Many who are in the justice system do not even have a high school education. And the chances of having somebody in the justice system with any kind of college education is very, very low. Because of this sets the tone for their employment opportunities and their ability to make a decent income by legal means. They also have limited access with no choice for health care once they're in the justice system. Once you're in prison, you do not get a choice of where you're going to go or who you are going to see for your healthcare services. Similarly, when they are outside of the prison system, they tend to come from areas where they do not have great healthcare insurance or easy access for their healthcare services. There is often familial or historic trauma within the family setting, and I will talk about that a little bit more in a moment. They typically have live in neighborhoods that are unsafe, or they feel that they are unsafe, and therefore they do not have free access for pleasure, walking outdoors, enjoying nature. And again, we've talked about the lack of employment opportunities. But in summary, these are some of the social determinants of health that are unique to the justice-involved population. What is so difficult about this is that it has become such an issue that Healthy People 2030 actually came up with a measure where they wanted to reduce the proportion of children with a parent or guardian who has served time in jail. And Healthy People 2030 identified this because children who have a parent or a guardian who has been in the jail or prison system tend to live in poverty, potentially be homeless, witness violence, whether domestic or otherwise. And these children start to develop their own behavior issues. And it's been noted that this can be speech problems, attention deficit, difficulty in social settings. So there is a cycle here of familial and historical trauma for children that continues this cycle within the justice system because of their social determinants of health. And we've talked in this semester about ACEs, or adverse childhood experiences. And these are some of the experiences that contribute to the cycle of being in the justice system within a family, for example. I'm going to change the topic a little bit now and talk about the health statistics for the justice-involved population. Not only are the demographics for justice-involved disproportionate as compared to the overall U.S. population, but their health statistics are as well. The Prison Policy Institute did a really nice job of analyzing data from the Bureau of Justice Statistics and presented this information. And you can see they're taking a look here on the slide at 4 different health topics. Asthma is on the far left-hand side, and what you can see here is that those in the prison systems are over 2 times more likely to have asthma than any adult in the United States. Likewise, hepatitis B, you are 3 times more likely. Hepatitis C is almost 5 times more. And HIV or AIDS, you are almost 3 times more likely to develop these conditions if you are in the justice or prison system as compared to the free world in the United States. Hepatitis B, C, and HIV and AIDS, those last 3 conditions that are listed, are all communicable diseases that can be prevented through education, early diagnosis, treatment, and learning healthy behaviors. Unfortunately, these are more prevalent in our prison systems than in the United States, and we will take a look at these a little bit more. Hepatitis C is a great example that I wanted to share. Hepatitis C is it's highly treatable. Yet, you can see from the slide here, the Prison Policy Institute has shown very nicely how the majority, 4 out of 5 people in the prison systems, still have hepatitis C, even though it can be treated. There are many reasons for this that we'll talk about, but again, the prison systems don't want to treat because they don't want to diagnose, because a lot of this costs them money to do in the first place. So this is setting the picture and kind of contributing to the overall problem. When you have hepatitis C in a population and it's not being diagnosed or treated, it's going to continue to transmit. This is also some statistics on the sexually transmitted infections comparing the U.S. population to those justice involved. This information came from the CDC as well as the Prison Policy Institute and the Bureau of Justice Statistics. Sexually transmitted infections continue to be a health problem for the United States. You may have been hearing more and more about this as different strains become antibiotic resistant. But these are occurring in the United States over almost 50%. You can see here 46% are occurring in the age group of 15 to 24 years old. As you can see, for the justice-involved individuals, the sexually transmitted diseases are evenly distributed across all of the age groups. The only age group where it reduces is 65 and older, but it's still over a 2% rate, showing that there is still a lot of activity occurring within that age group. The risky behaviors are what contribute to some of these communicable diseases and the continued transfer of them. High-risk health behaviors of those in the justice system are often a consequence of their lifestyle and choices that may have led them to their illegal activity. Such things can be drug use, needle sharing, prostitution, and some of this correlates back to they're simply trying to make money or survive, and that relates to the social determinants of health that we had talked about.
Hi, my name is Whitney Ringer. I worked as a nurse practitioner in infectious disease, treating many communicable diseases, oftentimes in patients who were incarcerated. Hepatitis C, HIV, and sexually transmitted infections are unfortunately common amongst the correctional population. Risk factors of these communicable diseases can include needle drug paraphernalia sharing, prostitution, or tattoos done with dirty needles, oftentimes in homes or on the streets. Given the risk factors of these communicable diseases, many of these individuals end up in prison for their behavior. Treatment is essential in stopping the spread. In my experience, treatment for this population is very difficult. However, the risk of infecting others remains high because of the close quarters they are living.
As you can see in this picture here, this is a picture of an actual prison in the state of Illinois that was taken in 2015, and you can see how congregate living basically is putting human reservoirs in a huge incubator, and these communicable diseases just proliferate if they are not diagnosed and treated. We learned in COVID-19 that nursing homes are congregate living facilities that required a high level of public health measures in order to prevent further transmission. Prisons are honestly no different, and as a matter of fact, they're probably more high risk because of the rate of individuals coming and going out of the facilities over time. Interventional failures that have happened in the prison systems. Typically, they are not offering testing or screening, so what you don't know, you can't treat or you can't even discuss. So they're not testing, they're not offering the treatment. The drug treatments can be expensive, and they simply are not wanting to expend those on their individuals. Treatment restrictions are very cumbersome. They are loosening up a little bit, but there historically has been treatment restrictions due to sobriety. So an individual had to be tested for drugs or alcohol and be clean, or they were not allowed to have these medications, or their level of infection was too low. So if the viral load was not high enough, they were denied treatment as well. And then external pathway to continue treatment once out of the prison system. Simply just discharging them when they're mid-course on a drug treatment or have been diagnosed without any resources does not help them, and it does not stop the transmission from occurring. Some of the intervention successes that have happened, they call this opt-in versus opt-out testing, which means upon entry into the prison system, everybody is tested as part of their intake and physical exam assessment, where historically they would ask them if they would like to be tested. So that is the opt-in versus opt-out testing. Once you can diagnose quickly, you can begin to offer treatments. Treatments for hepatitis C, for example, you can cure somebody with hepatitis C within 8 weeks. So again, the sooner the treatment is started, the faster we can cure some of these illnesses. Obviously, HIV/AIDS, you cannot cure it, but you can significantly lower their viral loads and help them. And then again, some of the successes have been education to prevent transmission. We're going to talk about that in a little bit more in the next slide. Some of the solutions that I propose to reduce communicable disease health disparities are removing the testing barriers. Again, we need to have point of care testing available in all prison systems and do it upon entry. Establish treatment protocols where the medication is readily available. If we have to rely on ordering or shipping medication, it's not there at the time that it may be needed. Provide education and peer support groups. And re-entry support to continue treatment and healthy behaviors. Peer support groups are essential. Culture matters, and we learned that this semester as well, that if they can learn from their peers, they are more likely to buy into the behaviors and the specifics for reducing their transmission. Incarceration should not equal health disparities. Simply because of your address, that should not determine what is going on with your health status. Implications for the U.S. public health as a general. Communicable disease transmission increases in congregate living facilities, and prisons are just where individuals who have high-risk health behaviors reside. Diagnosing and treating while in prison reduces opportunity for transmission not only among facility peers, but once they are paroled or back in the free world upon U.S. population also. Ultimately, we want to break the cycle of transmission. Public health is everyone's health. Your legal status should not dictate your health status, and public health is everyone's health, and communicable diseases don't discriminate based on your address or your legal status. I thank you for your time and attention.